A lot of men think that the function of the heart is to keep the male member functional, but a cardiologist may think otherwise. I'm very excited today to have Dr. Estela Apolinar in the studio. She's a board-certified cardiologist, and we are going to talk about primary prevention of something called cardiovascular disease. Welcome to the studio.
Thank you very much.
All right. The American College of Cardiologists came up with a new guideline just last month on the primary prevention of cardiovascular disease. Would you let the audience know what is cardiovascular disease?
So most of the time you'll hear it as ASCVD, and that's atherosclerotic cardiovascular disease. And basically that is a buildup of plaque in the arterial walls of the entire body. And with time, the plaque can build up and it can cause blockages that can cause symptoms such as chest discomfort, heart attacks, strokes, and also difficulty in walking that is caused by occlusions in our legs.
Now, how do people like cardiologists and primary care doctors, how do they assess someone's risk for cardiovascular disease or ASCVD?
So the prevention guidelines want us to focus on a calculated risk that we use, and it's an equation where we take into factors such as someone's age, their gender, their blood pressure, their cholesterol readings, and then we form a risk, and we decide if someone's low risk, intermediate risk, high risk, or borderline risk, and then we make decisions on how we treat them. But the principles that we usually involved is what's their cholesterol, what's someone's blood pressure, what's their family history, and also are they diabetic? Because those are factors that are strong indicators for coronary artery disease or cardiovascular disease.
Now, I've also heard something about calcium score. Can you talk to us a little bit about calcium score?
Sure. So a calcium score is obtained when we do a CT scan or computed tomography of the heart, of the coronary vessels. And basically, calcium is a marker of inflammation. So we see elevated calcium levels that are plaque or build up in the arteries, and the higher one's calcium score, the higher the risk of coronary artery disease or cardiovascular disease. So we have a scoring system that we use.
And I'm going to show on the screen a table of calcium scoring, indicating the score and also the presence of plaque and how what that means.
Right.
And so we talked about the calcium scoring. We talked about the how you estimate atherosclerotic cardiovascular disease. What is in the guidelines? It also mentioned something about nutrition. What is the role of nutrition? How do you counsel your patients when it comes to preventing ASCVD and nutrition?
So we want our patients to avoid transaturated fats. We want them to focus on a plant-based diet, like the Mediterranean diet, focus on fresh fruits, vegetables, less sweetened products like sodas. We also want them to eat less, more vegetable or vegetable-based diet, more fish, legumes, which are like peas and lentils, rather than saturated fats, which are found in red meats.
Sounds very reasonable. Sounds like it's everything that we've heard about, but it's so difficult to do.
It is, because usually eating healthy is not very inexpensive. It is expensive to eat healthy products sometimes because sodas are inexpensive, chips are inexpensive, and so we just have to try to work around eating things that are fresh, cucumbers, plants.
And chips are easily accessible. You just open up the can and then you can have your soda.
Exactly.
Now, I've heard varying things talked about regarding the role of salt. Sodium plays a role in kidney stone, calcium kidney stone formation. So I talk to my patients about sodium, and a big part of sodium we get most of our sodium not from added salt to our food, but from processed foods like chips, like you mentioned.
Chips, and also processed meats like delis, pepperoni, salamis.
Oh, yeah.
So those are very high in salt. And sometimes my patients don't realize that a ham sandwich has a lot of salt, especially because it's processed meat. So sodium plays an important role in our blood pressure control. So usually with the DASH diet, I think we've heard of that, when we want to lower our blood pressure, we want to consume sodium or salt that's less than 1.5 grams or 1,500 milligrams if possible, which is sometimes a little hard to do. But if we read the packages, for soda has a lot of sodium. And so those kind of products alone, without even adding salt to our diet, we can get quite a lot of grams in that.
Okay, now here's a big question. I see a lot of patients, and I'm sure you do too, with body mass index that's really high. Obesity, the big problem. The epidemic in the US, and I see it and you see it. When it comes to surgery, it becomes even something as straightforward as vasectomy, it becomes a lot more challenging when a patient is obese. So how do you address that obesity epidemic that is happening in the US?
That's a good question. So if my patients, I take it in a stepwise process. You don't want to tell someone they need to lose 100 or 150 pounds. It's overwhelming. So we take it one step at a time. A lot of patients or people don't know that a weight loss of 10 pounds is statistically significant. So when someone loses 10 pounds, 3 things get better. Their sugar gets better, their blood pressure gets better, and their cholesterol gets better. So we focus on exercise and diet. Diet is 90%, exercise is 10%. Of course, we want our patients to exercise, but we like them to eat foods that not at restaurants, eat in more. I always talk to them about Weight Watchers or MyFitnessPal, where we can control our calories and our intake and eat small meals rather than large meals and skip meals. Sometimes that's helpful.
So small meals throughout the day instead
small meals, low calorie throughout the day. I had a patient who said, "Well, I don't eat a lot." She said, "I drink a frappuccino in the morning and a frappuccino at night." And what she didn't realize is that has 15 calories in each frappuccino. So she's not getting 1,500 calories. So that's 3,000 calories. And when you want to limit your calorie intake to say 1,300 or 1,250, you've consumed 2 days of calories in that with no nutritional benefits.
Yikes. So what about when you mentioned physical activity? What is the current recommendation when it comes to physical activity? Looking at me, I believe it or not, I am considered overweight when you look at the body mass index.
Yes, because anything greater than 25 is considered to be
I'm
heavy.
just a little here over 25. So I'm working on becoming more physically active on the treadmill and things like that. What do you tell your patients when it comes to
keep it simple? I mean, sometimes if they say they work a lot, I'll say I'll take what I can get. Usually the recommended is 150 minutes a week of moderate activity. So I say, if you can do 30 minutes 5 days a week, that would be fantastic. If you want to ride your bike and you do 10 miles per hour, or you're swimming, which is considered vigorous activity, then that is 75 minutes a week of vigorous exercise. So I try to keep it simple for my patients. They can take a day off on the weekend. If they can do 30 minutes for me 5 days a week, I'll take it. But any activity, avoid sedentary lifestyle. That's all we're asking. Walks after dinner, walks after breakfast, taking the stairs instead of, or parking far away from your office is what we recommend.
I like parking far away because I like to park far away to protect my old car's paint job. You also mentioned diabetes, which is something that I also see. I don't treat diabetics, but I often see sugar spilling into their urine. So even non-diabetics, and I'll say, okay, I think you need to get checked out for diabetes. And I've diagnosed a lot of guys with diabetes that way.
Sure.
So there are a lot of newer medications. I know there's some older medication that do not prevent cardiovascular disease, and like the sulfonylureas, and then the newer medications are pretty interesting. They tend to they've been shown to prevent ASCVD.
Right, and those are names like Trulicity that you hear about without getting into the class of medications. But those have shown over time to decrease the risk of cardiovascular disease. The mainstay is going to be metformin, and that is still the primary, the first medication is a go-to. It's inexpensive, it's well tolerated, it helps in weight reduction. But metformin is a medication that is the first line of choice.
So what about lipid levels and cholesterol levels, and how do you manage guys and gals who have high levels or abnormal values?
So the risk calculator that we talked about earlier helps us risk stratify patients. And to keep it simple, there are basically 4 groups that need statins. If you've heard of Lipitor, Crestor, Lovastatin, those are statins. And when I tell my patients about cholesterol, the LDL, and I always tell them L for loser, L lower the better, that's the bad cholesterol. And for diabetics, those are the high-risk patients. We want to use statins if they have, cardiovascular disease, we want to use high-dose statins, high-intensity statins, such as Crestor and Lipitor. In patients whose LDL is greater than 190, we definitely want to institute statins if they're persistently elevated, even though they've done a non-pharmacological therapy like weight loss, exercise. There's a genetic component. If diabetics are between the age of 40 and 75, they're at highest risk. The number one killer of men is heart, number one killer of women is heart, and number one killer of diabetics is heart. So we tend to use statins in diabetics because they usually tend to be at high risk as well. So if you have a history of coronary artery disease, peripheral vascular disease, had a stroke, a mini stroke, or even an aneurysm that is because of atherosclerotic disease, we recommend statins. Those tend to be one of the main focus of the guidelines, is to lower the LDL by 30 to 49% in patients who are moderate risk on our calculators, and high risk, lower the LDL by greater than 50%. So we're not focusing on numbers per se, but reduction in percentages.
Those are real. I mean, that's a really drastic reduction in the amount of LDL. It is.
But we've seen, for example, in the calcium scores that you mentioned earlier, if someone has a calcium score that's elevated, they're at higher risk for coronary artery disease. So if we treat them with statins and they have, so someone, for example, if my dad has heart disease at 50 and my cholesterol is fine, and I don't want to go on a statin, but I get a calcium score and I have elevated calcium, then that may convince me to take a statin, because statins, we know that decrease the lipid component in the plaque in the arteries, so the gooey stuff that's in the plaque, and that can reduce the risk of that fat breaking off and causing a heart attack. So it reduces that plaque level in the arteries by using statins.
So speaking of killers, you said heart is the number one for men and women. Hypertension, high blood pressure is something that I see even healthy.
The silent killer.
Yes, the silent killer. And I tell my vasectomy patients that when they come in and I see their diastolic over 100 on repeated measures, they're a brand new patient to me and they've never been diagnosed with hypertension, and I send them directly to the cardiologist, even though they have absolutely no symptoms, no shortness of breath, chest pain, headache, nothing. And they're like taking time bombs, taking time bombs.
Right, because their first symptom is usually the stroke. And so sometimes, again, that's why it's a silent killer, because a lot of times they don't have symptoms. They feel fine. And when we treat patients, we usually want to keep patients less than 130 over 80. And we use non-pharmacological therapy first, always. That's incorporated in all our treatments.
So what do you mean by non-pharmacological?
So we want them to lose weight. And again, 10-pound weight loss when we start seeing changes. We want them to lower their salt or sodium intake. We want them to start exercising, because those are very effective and profound at lowering blood pressure. It's very underestimated. People think that if they don't, I'm just going to take medicines. No, it's very effective to lose weight, lower their sodium intake or salt intake, and start exercising. And when we do a calculation of the risk at every visit, and we find out through the calculation that their cardiovascular risk is greater than 7.5%, and their blood pressure is greater than 130, the top number and the bottom number is greater than 80, then at that time we say, well, your risk is high for cardiovascular disease, and we want to incorporate your exercise diet, but we also want to use medications to start lowering their blood pressure so that top number, systolic blood pressure, is less than 130. And
so they don't stroke out, they don't have a heart attack.
Long term, they don't have problems with coronary artery disease or cardiovascular disease.
It makes sense. What about something that I see is bladder cancer? And bladder cancer is highly associated with tobacco use. Right. Tobacco. Exactly. What is the role of tobacco in cardiovascular disease in your world?
So in the prevention guidelines, they want us to treat it as a vital sign. So we need to ask the patient at every visit, do you smoke? And if you smoke, how can I help you quit? And there's different options of quitting. There's, gum, there's medication, there's hypnosis. So we try to focus on and showing the patient different options of why tobacco use is hazardous to their health. It increases the risk. Even 2 cigarettes a day, which most people don't think is a lot, increases the risk of heart disease by 50%. And a lot of people don't know that, oh, I just smoked 3 cigarettes and it's not a big deal. It is a big deal. So we definitely want to address their tobacco history and their use at every visit, and let them know that we can help them. And there's a lot of options out for them. And it's a multidisciplinary approach. So we also have the primary cares. Every physician has to play a role in that as well.
Believe it or not, just today alone, I saw a bunch of new vasectomy patients, and at least 3 had history of tobacco use. And I talk about their increased risk of not just lung cancer, heart disease. I also address with them, if they ever see blood in the urine later on in their 60s and 70s, make sure they seek urologic care, because bladder cancer is so highly associated with tobacco use.
And it's the easiest risk factor to take care of, right? You just quit. I mean, it's not easy to quit. Correct. But it's a modifiable risk factor that makes a big difference.
Correct. What about electronic cigarettes? What did the guidelines suggest regarding that?
There's still not enough known about electronic cigarettes, so we don't advise it. We don't recommend it. We don't know the long-term hazards involved in it, and so the jury's still out on that. So it's not recommended that we instruct them to use that instead of tobacco cessation. There's other forms that are effective.
Okay, lastly, something really interesting: aspirin, baby aspirin. I
no
see,
longer we're parting ways.
Yeah, I see. I mean, pretty much all the older patients are on baby aspirin. What is the latest? Right. This is something that is brand new. That is kind of like something different than what's been done in the past. And I wonder how long this will take to trickle down to all the nurse practitioners, PAs, physicians, etc.
So before, we used to say if someone's at risk for coronary artery disease, like for example, they have 2 risk factors. So they have high blood pressure, high cholesterol, let's put them on a baby aspirin. And now we limit the use of aspirin 81 milligrams to patients who have disease. So who have heart attacks, who've had strokes, who've had stenting to the coronary vessels or any part of the arterial system. Those patients definitely are indicated for an aspirin because that's secondary prevention. But primary prevention, so in patients who don't have a history of cardiovascular disease, it's very limited, and especially in patients who are greater than 75 years of age. We do use aspirin in patients who are greater than 75 years of age if they have coronary artery disease or reason, but we want to make sure that they don't have a high risk of bleeding, because usually after the age of 65, that's when the risk goes up in terms of bleeding. Diabetics, again, very high risk, so it's a calculated risk benefit. We at times do advise because they're at high risk, but we have our calculated risk stratification and determine if aspirin is indicated for those patients as well, because they may have a high risk of bleeding and there's a risk benefit there.
So I see a lot of patients who are on blood thinners, and sometimes they're also on aspirin. How does that work?
So, for example, patients can be on blood thinners if they have atrial fibrillation. So it's a rhythm that number one complication is stroke. So if patients have atrial fibrillation, we do recommend medications such as warfarin or Eliquis, Pradaxa, those medicines that you've heard. Now, if they don't have coronary artery disease, they don't have peripheral vascular disease, stenting in the other vessels, we don't use aspirin in those patients. But if they've had a heart attack or they've had stents, then sometimes we use a baby aspirin in that, especially if they've had stents. We use actually stronger medications like clopidogrel, Plavix, Brilinta, and we use those for a designated amount of time. We don't use what we call triple therapy, so we don't use aspirin and Brilinta and a blood thinner because their risk increases. So usually if they have a stent, we try to limit to a medication that's a super aspirin called Plavix, so the stent doesn't close, and also the blood thinner. Those two are the medicines that we tend to use to prevent that. But we don't recommend aspirin with anticoagulation such as Coumadin or Pradaxa if they don't have a strong indication for aspirin, because there's 2 different mechanisms. They do work differently.
So what should people who have absolutely no symptoms and they're just walking around, they feel fine, they're say 50 years old, what is the recommendation when it comes to assessing the risk?
So how do we assess someone? So we ask them about their risk factors. So did your mom have a heart attack at younger than 65? Did your dad have heart disease or heart attack or stents or a stroke younger than 50? Family history is very important, but also siblings. Did your brother or sisters have heart disease? And usually it's females less than 65 years of age, males less than 55 years of age. If they have no history of we want to assess their blood pressure, what their cholesterol is. Also, do they have kidney disease? And people don't know this, but rheumatoid arthritis, it's an inflammatory process. HIV, cirrhosis. Number one killer of patients with rheumatoid arthritis is heart disease. Number one killer of patients who have kidney transplants or kidney disease is myocardial infarctions or heart attacks.
Wow.
So they're inflammatory processes that need to be taken into account when as a patient comes to our office. We go through all their history, their medications, their family history, and then we formulate a risk to see if they need any kind of therapy or screening, such as the calcium score.
So basically, you kind of have to visit a primary care doctor or
a primary care physician, and if the primary care physician believes that they need further evaluation, then they send them to a cardiologist.
So when does that transfer take place? I think just simple, straightforward hypertension, the primary care doctor can take care of, right?
Yeah, sure, absolutely. Sometimes the patients are a little bit more difficult because they have blood pressure that's difficult to control, or they're having side effects from the medication. So then we help them, and we work as a team to try to lower the blood pressure and get little side effects and simplify their regimen.
Sounds great. Well, I think I've taken up enough of your time. Thank you so much for coming here. I know you have family in town, and I really appreciate you coming in. If somebody wants to reach out and see you for their heart disease or medical therapy or atrial fibrillation or whatever, how do they get hold of you?
So I'm with Sun State Cardiology, and we have several offices in Gilbert, Chandler, and Tempe, and our phone number is 480-821-3800, and we'd be happy to see them.
All right, there you go, guys. If you guys have any questions, please leave them in the comments below, and I will try to coordinate with Dr. Estela to try to figure out how to answer them for you. Thank you so much for watching. If you're watching this on the replay, I really appreciate it. Take care and have a good night.
Good night.